Good afternoon and welcome to the sarcoma program. My name is Dr. Krista Goulding. I'm one of the orthopedic oncology surgeons here at Mayo Clinic in Arizona, and I'm joined by my multidisciplinary team, including Dr. Mahesh Seetharam, Dr. Jonathan Ashman, Dr. Alanna Rebecca, and Dr. Nathaniel Hinckley. And so I'd like to go through some of the general treatments around sarcoma care from diagnosis through survivorship. So today we'll be focusing on identifying key components of treatment, health-related quality of life, and the patient experience in an individualized sarcoma care model. So what is cancer? Essentially, this is tissue growth despite the absence of stimulus. And you can see here in the pictorials, a patient with a sarcoma involving the arm.
Go ahead and share content, Doctor.
Yeah, I don't see your screen, Krista.
Okay, I apologize. Let me go back here and there we go.
Okay.
Are we able to see that?
Yep.
Okay, great. And so here you can see a sarcoma involving the soft tissues of the upper arm. In the middle picture, a sarcoma, an osteosarcoma that is coming outside of the bone, and a histology slide. And so cancer is can essentially be inherited or acquired. This is a predisposition to cell mutation in the inherited version. And acquired can be exposure to a carcinogen or a sporadic replication error in our DNA. And for sarcoma, for the most part, these are acquired, basically sporadic mutations. And so what is sarcoma in particular? Sarcoma is bone and soft tissue cancer. It's very rare. It makes up about 1% of all cancers, and it's quite a mixed group. Basically, these cancers arise in the bone, cartilage, muscle, fat, in the nerve sheath, and around the vessel wall. There's over 100 different subtypes in soft tissue sarcoma, and in bone sarcoma, there are also a number of them, the most common being osteosarcoma, Ewing sarcoma, and chondrosarcoma. The incidence of disease, so how many patients have this in the US? There's around 13,000 new cases of soft tissue sarcoma every year in the United States, and around 3,600 cases per year of bone sarcoma. And so this gives us around 30 cases per million per year overall in the world for soft tissue, for soft tissue and bone sarcoma, as compared to benign or non-cancerous tumors that are around 3,000 per million. So you can see it's quite a low incidence. Patients usually will come to see us with a lump in their leg, and it can be as big as the one that you see here, or it can be a tiny little lump that you feel underneath the skin. Generally speaking, for soft tissue sarcoma, these tend to be painless, and the majority that we see are bigger than a golf ball, so around 5 centimeters. The majority will happen in the lower extremity, so in the leg or in the arm, but we do see it all around the body. The typical age, really sarcoma affects everyone from infants all the way to the elderly. The mean is around 50, and generally speaking, we see patients around 30 to 90, in particular in soft tissue sarcoma. Males and females can get this in equal proportions, and there is an increased risk in some patients who have genetic syndromes like Li-Fraumeni or neurofibromatosis type 1. Some patients who may have had treatment with radiation therapy for other reasons, and then patients who've had chronic soft tissue injuries or lymphedema in the past. Red flags, a lump that's over the size of a golf ball, any rapidly growing lump, and any lump that's really deep in the leg or in the arm. Some of these are painful, but for the most part, these tend not to be painful, but if they are growing to such an extent that they're starting to push on nerves and things in the vicinity, these can become painful. Patients who have osteosarcoma or bone cancer will typically see them in their 20s. This is in their sort of teens and 20s. This is a childhood cancer, and the most common sites are in the leg. And the picture on the top is an MRI image of around the knee joint. And you can see the grayed out portion of the bone on the left-hand side is abnormal tumor within the bone. Some of these can be hereditary, as I've mentioned before, as well in bone cancer. And we typically work these up with staging. So usually we scan the chest, we'll get a bone scan, and then we perform some blood work. Some patients will come to see us for the majority with the tumor that is really just localized in the bone only, and other patients will come to see us where they've already had metastatic disease or cancer that has already spread to the lung, and that's in around 20%. And everybody needs a biopsy in order to determine what this is and how to treat it and how aggressive it is. Ewing sarcoma we tend to see in patients who are just a little bit younger than patients with osteosarcoma. This is again a bone cancer, the second most common type. And these patients usually actually present with pain and quite a big lump in the leg. And the most common sites are going to be the thigh bone, the lower leg bone, and the upper arm bone. But we also see these commonly in the pelvis and also the spine. Chondrosarcomas is the third most common bone sarcoma that we treat. And this tends to be more of a disease of adulthood, typically from the age of 40 to 60. And these are cartilage forming tumors. And you can see here, this is an x-ray of the knee. And you can see an x-ray on the top and a CT scan of the knee on the bottom. And the white fluffy area, this is cartilage matrix. And so this is a bone forming tumor that is trying to put down cartilage. It typically also happens in the thigh bone, the lower leg bone, and then we tend to see it as well in the pelvis quite commonly. Diagnostic approach, meaning how do we find out what these sarcomas or what these cancers are, these lumps are, and then how do we treat it from there? First, we do a biopsy, and grading tells us how aggressive the tumor is. So these could be low grade, intermediate grade, or high grade. The higher grade ones tend to be more aggressive. And then staging reflects how big is the site of the tumor and also what's the extent of the local spread. So has it spread to the lymph nodes and has it spread elsewhere in the body? And we use this to guide our treatment. So in terms of our treatment, this is quite a team approach, very multidisciplinary. We have a large number of team members, both from the radiation, medical oncology side, and as well a number of surgeons who are involved in caring for these complex problems. For soft tissue sarcoma, generally speaking, patients will have surgery and radiation, followed by removal of the tumor, or what's called a wide excision, meaning taking the tumor out all as one piece without any contamination. And then we'll use a preoperative or intraoperative radiation therapy. For bone sarcoma, this tends to be chemotherapy and surgery, or surgery alone, depending on the type of sarcoma that it is. In terms of types of surgeries that I do and my team will perform, in over 90% of patients, and even up to 95% of patients, we can save the limb, and this is what is called limb salvage surgery. So we have a twofold purpose. Essentially, a safe oncologic resection, meaning getting all the cancer out as one piece, and then a functional reconstruction. So saving life and then saving leg and trying to maximize the function of that leg as much as possible. As I mentioned, our goal is a wide or negative margin, meaning that we take a margin of normal tissue around the tumor surface. Ideally, that's a few centimeters of muscle or fascia. We try to preserve the limb wherever possible, and then we want to maximize function for patients in line with their goals and expectations. And so here you can see a whole femur that's been removed on the right-hand side here, and a big metal endoprosthetic reconstruction, which is going to reconstruct the patient's thigh bone and allow them to save their leg. We have a whole host of reconstructive options for bone sarcomas, and these can involve anything from what we call endoprosthesis or megaprosthesis, meaning that we're replacing a large segment of bone. We use the very latest technology in terms of 3D printed models that are actually specifically printed for patients' own anatomy. So whereby we will model the patient's pelvis, for instance. We 3D print cutting guides that will allow us to very particularly remove the cancerous tumor without taking too much tissue. And then we actually can fabricate and manufacture 3D printed models that will sort of fit in like a puzzle in order to allow us to maximize function. And those are very exciting advancements. We also use things called allograft prosthetic composites, which is a combination essentially of metal components and cadaver bone that we're able to use to reconstruct legs. We use vascularized autografts, so parts of bone taken from other areas that get then plugged in to help us with our reconstruction. And so a whole host of things. Here you can see x-rays starting from the left of the knee, the hip, which is an allograft prosthetic composite, the second slide. You can see this again in the knee joint. And then on the far right is a pelvic reconstruction using cadaver bone, although we've moved more towards 3D printed titanium metal implants more recently. As I mentioned, limb salvage is possible in over 90%. And what we can see here is actually a 6-year-old child who had developed an osteosarcoma of his lower extremity, unfortunately. And you can see a small metastatic lesion just above that called a skip metastasis. And so unfortunately, he needed an amputation, but we created a custom implant for him that actually is minimally invasively magnetically expandable. So that implant can grow with his lower extremity to provide him the best limb in order to create an external prosthetic that he can walk on. Endoprosthetic survival or survival of these implants is around 85%, around 10 years after surgery. And they can have complications like loosening or infection, and these are all problems that we continue to deal with over time. So we tend to see patients for at least 10 years in follow-up and sometimes lifelong, depending on the type of implant that they have. We have a dedicated cancer rehabilitation program focusing on prehabilitation to enhance the recovery of patients. And this is a focus of research that we're currently doing at the moment. And we're really moving towards preference-based outcomes. So really capturing what matters most to the patient in our research programs and their experience with the healthcare process, and then utilizing those things in order to create programs that will enhance recovery and enhance function for patients as much as possible. These are the different health-related quality of life domains that we've identified in sarcoma survivors, from experience with the healthcare system to psychological well-being, daily living, physical well-being, and the social environment. Each of those things will impact the patient's quality of life. And this is not going to be the same for everybody. Sarcoma is really all over the body, and so each person is unique in their experience, but there does tend to be general themes. You can see here some of those things are around experiencing side effects, physical limitations, health perception, so a feeling of anxiety and social isolation and withdrawal. And so we have a program where many of our patients get referred to psychiatry and psychology in order to help them work through a lot of those issues. We have a social worker that also will get involved, and a palliative care team that gets involved early on as well in order to help patients navigate many of the issues that come up. These are very difficult times and treatments. This is one of the programs that we're currently working on now from a research standpoint, is identifying a patient reported outcome measure that is specific to sarcoma. And this has been going on for several years now. So this is in the works. And this involves qualitative research around our patients and what their experience is, and capturing what matters most to them in order to try to help us make decisions that is in line with their goals and expectations. So this is really a team-based approach to personalized medicine in sarcoma care that involves surgical innovation and technological advancement. We have a complex reconstructive team, which involves myself and a number of other surgeons, including Dr. Rebecca and Dr. Tevin, who are our plastics and reconstructive team, cutting edge radiation and systemic treatments, which you'll hear about in just a moment from Dr. Ashman and Dr. Seetharam, and a dedicated cancer rehabilitation program that's directed by Dr. Sarah Park. And I'm happy to be a part of this team, and I'm going to turn it over now to one of my colleagues.
Thanks, Krista. That was a great introduction.
Thank you.
So as Dr. Goulding was discussing, quality of life and cure go hand in hand in this disease. We've known for a long time that for extremity sarcomas that we don't need to do amputation to cure patients. And so most patients are able to retain their limb, but we also know that no matter how good the surgery for these often aggressive, locally aggressive cancers, that local recurrence can be an issue. And so that's where the paradigm of combining radiation and surgery has grown out over the last several decades to try to still achieve the high rate of tumor control, but allow the surgery to remove the tumor and preserve function as best as possible. So radiation, when you look at radiation plus surgery or surgery alone, the chance for local recurrence is reduced when you add radiation. So that's really the rationale in many of these cases for us to collaborate with radiation. You can do the radiation before or after surgery, and from a cancer control point of view, seems to be about equivalent. There are pluses and minuses to doing it one way or the other. In many cases, in our paradigm, in our system, we see many of the benefits to doing radiation pre-operatively. From a patient tolerance point of view, patients tend to tolerate radiation better prior to surgery. In some cases, we can see the tumor shrink, although not always. Most of these tumors don't necessarily decrease in size very much. And then we can tailor whether any additional radiation as a boost, for example, needs to be done based on the findings at surgery. And often at Mayo in Arizona, we can do this extra boost radiation in the operating room as soon as the tumor comes out with intraoperative radiation. The benefit of this sequence is, number one, from a convenience point of view, it keeps radiation visits to a minimum. When you are finished with your surgery, you can focus on your recovery, and we're not planning on bringing you back for more radiation after surgery. And if Dr. Rebecca is planning any tissue skin grafts or other types of tissue transfer to help with the healing, then we're not going to threaten that with any additional radiation. Although doing radiation before surgery can sometimes make the healing more complicated and require Dr. Rebecca get involved. But that's okay, because she is part of the team from the beginning, so these decisions are made as a group. In some instances, the sarcomas can appear elsewhere where surgery can be really difficult. So, for example, in the pelvis, where major surgery may not be possible. There, in some cases, we can do radiation by itself or with chemotherapy to provide a cure, but sarcomas need very high doses of radiation to try to cure them on their own. That's where some advanced techniques, such as proton beam, as opposed to X-radiation, X-rays, may provide us with an advantage. Certain sarcomas along the spine or in the head and neck area can be more challenging surgically, and proton beam may provide us an advantage. So radiation plays a integral role for many patients with sarcomas, oftentimes before surgery, sometimes after surgery, and again, with the goal of maximizing the chance for cure and quality of life. Dr. Seetharam?
Well, thank you, everyone. My name is Mahesh Seetharam. I'm the medical oncologist seeing all of the sarcoma patients. And thank you for everyone for being here this afternoon, spending your afternoon. So what I would like to do is just give you a glimpse of what chemotherapy, or at least the discussion of chemotherapy, goes like when I see a patient with sarcoma in the clinic. But of course, as Dr. Goulding and Dr. Ashman mentioned, this is truly a multidisciplinary type of cancer. There is sometimes no right or wrong answer. That is why we try to sit together as a group, try to figure out what is the best treatment approach for a patient, what provides the best outcomes. So that is what we do in the tumor boards. So when people hear about oncology or talking about chemotherapy, of course, it's nerve-wracking because nobody wants chemotherapy. So again, when I see somebody in the clinic, especially for sarcoma, it is a long discussion. The reason is, first of all, that this is a very rare tumor. And as Dr. Goulding said, there are more than 100 types. That makes it quite challenging to figure out who needs chemotherapy and who does not. First of all, the approach would be, why do we need to use chemotherapy? And what are the indications to give chemotherapy? There are three different scenarios, if you will. One is, I might see a patient who has a tumor which is quite big and may not be appropriate for surgery or radiation upfront. We may give chemotherapy in that setting, what we call as a neoadjuvant, meaning before surgery, to try to shrink the cancer. And we look, after giving 2 or 3 cycles, when they go to surgery, hopefully the tumor is small and it's confined and it's easy to take out. Then we see what we call as a pathological response, meaning how many of these cancer cells appear dead when examined by the pathologist under the microscope. The more the number of cells dead, that's really good news, because that means the treatment, what we gave, is working. And that gives us more confidence in giving the chemotherapy after surgery if we need to give for a few more treatments. The second scenario is where we may have to combine that with radiation, what we call as concurrent chemoradiation. Again, there are few drugs which can be given that way, because many of the drugs, they may cause too much side effects when we combine with radiation. And certain drugs, like maybe you might have heard about ifosfamide or mitomycin, cisplatin, those are the drugs which we think about giving when we are combining with radiation, because they both have a synergistic activity and they kill the cells together better than using one or the other by itself. The scenario is called what we call adjuvant therapy, meaning giving chemotherapy after surgery. And the idea there is to decrease the risk of the cancer coming back. Again, for the last 35 years, there has been a lot of going back and forth who benefits from chemotherapy in that situation. The primary reason being, we don't really have a large database to go back and say, hey, yes, we treated 500 patients with this chemotherapy, with this sarcoma, and this was their outcome. Unfortunately, there are not that many patients with sarcoma, and that is not the way how it was studied in the clinical trials. They put every type of sarcoma together, everybody got the same chemotherapy, and they try to figure out what worked. Unfortunately, because their personalities are so different, all these cancers, they did not respond the same way. So the net result we would call was not beneficial. But fast forward now to 2015, the Europeans went back and looked at the data, and then they came out saying, well, the patients who had a big tumor and which were high grade, meaning more aggressive looking under the microscope, those are the ones who had the best benefit with decreasing the tumors and maybe possibly living longer. So that is where the science has moved now, looking at those kind of variables to try to decide who may benefit from giving chemotherapy after surgery. The last basket, if you will, is where the cancer has already spread, which happens in about 25% of the patients with sarcoma when they're first diagnosed. It may have already spread to other areas, other organs. That is we call a stage 4 or metastatic disease. In that situation, the treatment most often, again, not in everyone, most often what we call is palliative, meaning we are trying to just control the cancer and provide an acceptable quality of life, again, balancing the side effects of the treatment against the potential benefits of the treatment. So we're trying to control the cancer, try to avoid new cancer from forming, and hopefully give a good quality of life for months or years. So that is called a palliative stage 4 metastatic disease chemotherapy. And again, chemotherapy comes in different forms. Again, colloquially, everything is called chemotherapy, but chemotherapy is generally just the treatments which kills the cells directly. And that also tend to have the most collateral damage as well, because it also kills normal cells. So now, fast forward to 2018 to 2020, we have more targeted therapies, meaning we have identified certain targets on the cancer cells, which the cancer cell is depending on as a growth factor, as a feeding force to grow and multiply. So we're targeting those proteins on the cancer cells with this. Most often these are pills, and there are already a couple of them which are approved for sarcoma. And we utilize that strategy to kill those cells. And you might ask, what about immunotherapy? Why not? Yes, immunotherapy has been approved for about 14 cancers now. Yes, that has been looked at sarcomas as well. It's not FDA approved yet. The reason is in sarcomas, there are not too many mutations. You may hear about mutation in a cancer. Yes, many cancers, they change form and the rogue cells continue to multiply because of this mutation in certain genes, which gives them a growth advantage. But in sarcomas, unfortunately, there are not too many mutations. What is happening is more what we call as translocation, meaning to say there is genetic swapping of 2 chromosomes, the partner switch. So it is not a mutation, it is a translocation. So they're translocated to different genes. So that is why immunotherapy doesn't work too well. If you have too many mutations, you might have heard of a term called tumor mutation burden. If you have had a genetic sequencing done on the tumor, that is what the number signifies. If you have more than 8 or 10, you would be considered a higher tumor mutation burden. So that is generally what we are looking, which signifies the mutation. So that is where the role is. There is certainly is an evolving field. It's being tested in sarcoma in combination with radiation and also with vaccine therapy. So lots happening. Yes, there is. It's not as easy to say yes, it works or not, but it's just understanding where its role is. So if I'm looking at this again, clinical trials, I have to emphasize it because I strongly believe clinical trials are the way to go. That's how we got to where all the standard of care treatments are. It was not standard of care years ago. Now it is standard of care because of the clinical trials. Any new drug has to go through these trials. That's how it is approved. So I strongly believe participation in clinical trials, and we're lucky to have quite a few of them. And definitely that is where the field will, the pendulum will swing and the field moves forward. So I truly believe in it. And certainly I really promote clinical trials if it's an opportunity there. So with that, I will pass on the baton to either Dr. Rebecca or Dr. Goulding back again, and happy to answer questions at a later time. Thank you.
Thanks very much. I think Dr. Rebecca has been unable to join us this afternoon. She's in surgery at the moment. So I'd just like to thank all the presenters. It's great working as part of this team. As I mentioned, this is a real team-based approach. We essentially have each other on speed dial and speak multiple times a day on the weekend, on holidays. This is a real, real multidisciplinary team. And it also, and who I didn't mention prior to this, was our radiology colleagues who are specialized in musculoskeletal tumors. We have pathologists as well, whose particular focus is soft tissue and bone cancers, and they make up a big part of the team as well. Dr. Mahesh touched on the multidisciplinary tumor board, and this is a meeting that happens on a weekly basis with the medical oncologists, radiation oncologists, surgeons, and then radiologists and pathologists together. And we make treatment recommendations in these meetings, and that's a very significant part of the care that's provided as part of an expert sarcoma center. So I wanted to turn the floor over to see if we had any questions. And I think Dr. Hinckley was going to help us with moderating the session from that standpoint.
Yeah, I do. I have a list of questions to go through. Also, Dr. Rebecca is online now too, if she had any comments she wanted to make. Or I'm happy to start moving through this this list.
Dr. Rebecca, are you on the line?
I am. Can you hear me? Or
not? Just speak up just a little bit, I think.
Let me get my headphones. Sorry. Can you hear me?
Yes, that's great.
Okay. All right. I don't have a lot of comments to make. I think that as part of the multidisciplinary team, I am more or less the closer, so to speak. And when the rest of the team actually treats the cancer, sarcoma, and any any systemic or local treatments with chemotherapy, surgery, or radiation, I'm the person who comes in once the cancer therapy is completed in the acute setting and closes the wound. It can be a very straightforward closure, or it can be something that ends up being a pretty significant challenge depending on the location, size, and local involvement that the tumor creates. So we have done everything from an easy direct closure for something that's small and early in its growth, and we've done a significantly larger spare parts style surgery where we actually utilize portions that may otherwise be sent to pathology in an effort to close the wound, giving the least side effects from any other surgical site that we can for the patient. So I think that my job is extremely interesting in the fact that I need to really have a great discussion with the patient to come up with a plan that gives them the best functional outcome for limb salvage. And we do that with our multidisciplinary team to make sure that we're all on the same page and know what our surgical plan is even prior to entering into that day in the operating room. Nate, Dr. Hinckley?
Great. Yeah. So I just, before I start kind of going through what I have, any questions, feel free to just add into the Q&A section and I can pull from there as well. But to get things started, Dr. Seetharam talked a little bit about clinical trials going on at the Mayo Clinic. Is there any way for patients to find out more or kind of read up on available clinical trials going on?
Thank you very much, Dr. Hinckley. Thanks for the question, and thank you for the audience for asking the question. So yes, absolutely. So if you go to Mayo Cancer Center clinical trials, if you type it in, so it should bring it in. So again, if you put it as Phoenix or Arizona, it is more specific to what we have open here. If you just go to Mayo Cancer Center clinical trials, it'll show the trials which are open across all the 3 Mayo sites. So then you can filter it through sarcoma. You can type it as sarcoma and it shows up all the sarcoma trials. And you can also go to what we call early cancer therapeutics, which is the phase 1 and phase 2 clinical trials. And many of them are not just exclusive to sarcoma or any particular type of cancer. It could be more general to the specific genetic abnormality in the tumors. In the future, we will not be calling cancers by their names. We won't call it as lung cancer or breast cancer. We will be renaming all those cancers based on what the molecular abnormality is in the tumor. And the trials are more focused more towards what the Achilles heel of the tumor is, rather than just by the organ where it started from. Yes, to answer the question, yes, it's easy. If you go to Mayo Cancer Center clinical trials and type in sarcoma, it should show up those studies.
Great, thank you. Dr. Goulding, in general, when you start to see a patient for sarcoma treatment, about how long will you continue to follow or see them in your practice for?
The follow-up for sarcoma tends to be quite intense. Generally speaking, we follow the patients for 2 reasons. One is to make sure that there's no cancer that recurs either at the site of the surgery or has spread elsewhere. And the second reason for following these patients is the actual reconstruction, both from between myself and Dr. Rebecca and the plastics team in the early stages, and then also longer term, basically looking at the healing of bone and the overall survival of these implants that we're putting in patients that's allowing them to walk or use their extremity. So typically it's around a 10-year follow-up. The surveillance tends to be more frequent up front because the chance of a tumor recurring or even an implant failing tends to be larger in the first 2 years. So typically we'll see patients for every 3 months for the first 2 years. And then between year 2 and year 5, that gets pushed to around every 6 months. And then we see them on a yearly basis after that till around the 10-year mark. And And that can change based on if patients have a very low-grade tumor or a more aggressive tumor, but that typically is the schedule for follow-up or surveillance is what it's called. For patients who have an implant, we'll tend to see them after the 10-year mark around every 2 years or whenever they run into any problems. Many of these patients will be operated at very young ages, 5, 10, 20 years of age. And so you can imagine that these implants have to last a very long time. And so oftentimes we're seeing patients who've had very complex surgeries when they were a child that come back with implant-related complications later on that we then have to deal with. They've survived the cancer, but now we're focused on function, maximizing function and quality of life. So we do tend to have quite a relationship with patients over a long period of time as a result.
Great. Dr. Ashman, as far as radiation therapy and patients that receive radiation, what kind of changes around the skin might you expect? And as far as skin products, are there things that you would recommend patients avoid using, or specifically things you might recommend that they do use as far as skincare?
Yeah, that's a great question. The most common side effect from radiation for sarcoma, especially when we're talking about extremity sarcoma, is inflammation of the skin, or what we call dermatitis, which is essentially like a sunburning type reaction, which tends to build up over the course of the 5 weeks of treatment, can often peak at the end or the week or so after treatment. And there's really not too many products that can stop this from happening. It's more of a matter of managing it and soothing the skin. We use products like Aquaphor pretty regularly. There are some other subspecialty products that some patients find more or less useful. Some patients like aloe, some patients don't like aloe. Things like sunscreen don't work, and we can't really prevent it from happening. We typically recommend that patients come in for radiation with their skin clean and dry, and that these skincare products are best used, sort of after the treatment for the day. After radiation, when the skin breaks down and in the healing process, again, we have a variety of creams and lotions that can help promote the healing. And one reason why we wait typically around 4 or 5 weeks after radiation before moving on to surgery is because we really want the skin to heal. Obviously, Dr. Goulding wouldn't want to do surgery right through a big bad sunburn, but the skin is amazing and heals up. And usually by the time surgery rolls around 4 weeks after radiation, there's some darkening of the skin, but everything is healed up.
We have Tim Callahan on the line here who said that Myoderm has worked well for him twice a day after radiation. He utilized this on the leg. So thanks for pointing that out, Mr. Callahan. From my standpoint, from the surgical side, we typically do have a period of time prior to surgery, especially in patients who have soft tissue sarcoma who are undergoing radiation, to try to optimize or enhance the recovery after surgery. And part of that is after the upfront radiation, which is typically around 5 weeks, we have a rest period, and that's a good time for the skin to settle down prior to operating. We usually operate around 4 to 6 weeks after the radiation has been complete. And it does radiation allows us to get closer to the tumor so we can preserve more tissue and maximize the function of the limb. So in that preoperative period is a good time for prehabilitation or prehab. And so we're also focused in just beyond what we're doing from the skin standpoint, allowing that to heal, is trying to have patients involved in regular exercise and physical therapy programs in order to put their extremity in the best position possible to recover quickly after surgery.
Great. To either Dr. Goulding or Dr. Rebecca, as far as things involving the surgical site, what kind of things might you want to look for after surgery that would signal you would need to pursue further care, or might need to contact your provider?
From the local recurrence standpoint, meaning tumor that's come back in the area, I tell my patients that to have just an idea of what their own incision feels like on a longer term basis, and any hard nodule that develops in that area, or new pain when they didn't have pain there before, even in the interim between their visits, to come back and see me right away. And then we usually get those areas imaged. And patients are usually quite good about knowing their own bodies. And so we make that follow-up happen, quite rapidly, especially if it's something that comes up quickly, as these things can grow rather aggressively at times. Dr. Rebecca, did you want to answer around wound care?
She might have
She
signed
may
off.
have to step out. Yeah, I don't see her on the list actively. So.
From a wound care perspective, generally speaking, the follow-ups gets mixed between myself and the plastics and reconstructive team in the early stages post-operatively. Typically, the wounds will be healed somewhere around 3 weeks, but it does take a while for the wounds to mature. And we know that the collagen cross-linking can really take 6 to 12 weeks actually to get to their strongest. And so wounds can break down even if they've healed in the interim period. And certainly having something like radiation prior to surgery can lead to some of those issues, big wounds and big surgery, and then the addition of radiation therapy, which can cause some issues with the small blood vessels in the thigh. And so I also tell patients in the very early postoperative phase to keep a real eye on their wounds, and redness, fevers, new swelling. Those should prompt patients to come back sooner in order to rule out a wound-related complication or infection.
Dr. Seetharam, as far as diet when undergoing chemotherapy, are there any recommendations of things that patients either might want to avoid, or specific diets that would be recommended for them?
No, that's a really excellent question. Something I get to hear every time when I talk to patients about treatments. So again, generally, there is no specific recommended diet per se while undergoing treatment. But again, everybody asks me about what about sugar? So is it good to cut out sugar? Yes, based on animal experiments, there has been some evidence to say, yes, the rats which were fed more sugar had their cancers grow faster. That was an example of pancreas cancer, for example, but not really, which could be done in humans. But again, if you think about doing a PET CT scan, that is the other thing they think about. Well, you get a PET CT scan, you get a glucose dye, and it goes to the cancer site. So does that mean taking in more sugar is harmful? There are no direct data or evidence to cite, but yes, it would be good to minimize carbs intake. That is something which has been actively studied. Again, a very difficult long-term project, but again, that has been evaluated. But aside from that, just in terms of getting chemotherapy, people don't tolerate chemotherapy well if they're taking spicy or fatty foods. So that makes them sick, nausea, vomiting. So generally we want them to be on a sort of a blinder diet while getting chemotherapy, because we give them steroids with every chemotherapy, and that itself can cause gastritis and reflux and ulcers. So we want to minimize any added injury on top of the medications we're giving, try to minimize the risk of the side effects of chemo. So it's all sort of a balancing act. If you ask about immunotherapy, it's a very fascinating story with immunotherapy, because with immunotherapy, you're trying to take out the negative effect on the immune system so that it can fight the cancer cells, identify it more efficiently. So what it turns out is, as you may know, that most of our immune system is in our gut, the gut microbiome. It plays a huge role in trying to modulate your immune response to immunotherapy. So what they found is, again, this is all from the last 5 years, if you take probiotics, you tend to lower the benefit of immunotherapy. So there's only 2 strains which helps your immunotherapy to work better. But when you're taking a capsule with 50,000 strains, you have no idea what strains you're getting. So basically, we tell them not to take probiotics with immunotherapy because that has been studied and published to decrease the benefit from immunotherapy. So those are the few things which, anecdotally, I'm just off track here, just about a question about melanoma, because melanoma is fascinating because tomorrow there is a talk about melanoma. One of the things what came up is there is a mutation called BRAF mutation. So what it turned out is, this is about 3 years ago, patients who were on targeted treatment for that mutation, if they were on a keto diet, I bring up because keto diet is one of the more favored diets. So that cancer seems to like keto diet. So that cancers got worse in those patients who were on treatment for targeted therapy for that melanoma, that type of melanoma. So again, I think whatever we discussed today may be entirely wrong in a few months. So, but again, stick to general principles, healthy diet as much as you can, nothing to overdo. So as long as you're balancing all your proteins, vitamins, carbohydrates, and fat, I think you won't go one way or the other. That's what I would recommend.
Great, thank you for that answer. Just for anyone who wants to touch on this one, there are quite a few appointments that get made with all of the different providers here in the different departments. What things are available, or what kind of strategies are there working among us for coordinating care and planning out, getting multiple visits organized?
I can start with answering that one. We do have several sarcoma liaisons, one in particular in the musculoskeletal oncology world, so in orthopedics, where I work. And we also have a sarcoma coordinator in the medical oncology group as well. And so these are individuals that help the patient navigate the healthcare system. This can be quite a stressful time. Appointments can be lengthy. There can be many of them. There can be a lot of imaging studies or blood work to do. And so we try to do our best to coordinate all these appointments. And the sarcoma navigator is somebody that helps that happen. And there's sort of the link as well between the surgeon or the oncologist and the patient. We also have, of course, our administrative staff, our medical secretaries, as well as specialized sarcoma nurses who really help to facilitate the coordination of appointments. With the advent of COVID-19 and in this pandemic, we've had to really move towards more of a video visit-based strategy back in March. And in some ways, this has actually helped our practice in terms of patients who are coming from far away, so either internationally or who are simply traveling to get to us by car or by plane. And so we see this quite commonly. And so we're able to organize a video visit up front, generally speaking, in order to try to understand what the patient's diagnosis is, if they have one already, what imaging they've had, get all that information and documents and imaging studies over to us so that when the patient does travel to see us, that we have a very good understanding of what needs to be done and we can coordinate all of that in a very timely manner.
Great. Dr. Ashman, as far as another kind of aspect of treatment, how frequently do you see patients experiencing fatigue with their radiation therapy, and how long might you expect that to last, or is there anything that can be done to kind of mitigate?
For most cases with, we talk about fatigue associated with radiation very commonly. It does depend a little bit on what area we're treating. So the issue of fatigue is a lot less when we're treating an arm or a leg compared to someone who might be getting radiation to the mouth or throat or chest. Now, if we're treating a sarcoma in the abdomen or pelvis, for example, for retroperitoneal sarcoma, fatigue might become more of an issue. Typically, again, this is a type of side effect that will build up as you go through the treatment. Part of that fatigue is from the radiation. Part of it is just coming in every day. You know, most radiation treatments are daily treatments, Monday through Friday. They may only last for 15 or 20 minutes, of which of that time, only a small fraction is the actual beam delivery. Most of the time is spent making sure that we've got you in the right place on the machine, that we're on target. So some of the fatigue is simply having an appointment 5 days a week for 5 weeks, coming in every day, getting in the car, changing your routine, and it can build up over the course of the treatment. Usually the fatigue will fade away within a few weeks. Again, another reason why we tend to wait some period of time, have a rest period, recovery period between radiation and surgery to make sure that patients are strong going into surgery.
Great, thank you. That's all I have for questions right now.
Great, well, thanks very much. I was just wondering if each of us could go through, I'd actually like to understand as well, what do you think is the most important or significant advancement in your own subspecialty that has improved sarcoma care in the last number of years? Dr. Seetharam, maybe I'll ask you first. You gave us a great synopsis of how things have changed over time. And certainly there's a lot of medical advancements and interesting innovation and technology, that's currently available to patients that wasn't 30 years ago. If you had to pinpoint one thing, what do you think that might be that's improved care for our patients?
That's a great question. Thank you for asking. I think understanding sarcoma is not one cancer. There are many different types, are very different cancers. I think that is the most important realization we have had for many years, because that is what has enabled us to do clinical trials. Even though there may not be huge trials because of the limitation of the numbers, we can at least do dedicated studies with smaller baskets and at least treat them the one way, and at least we will know yes or a no. Because for the last 40 years, putting 19 clinical trials in a meta-analysis looking at their outcomes, we came out saying, boy, it doesn't work. And that was almost 2,000 patients. So if we can just forget about the 30 years of what we have known and just move forward in the next 5 years, understanding the molecular, the genetic underpinnings of these different sarcomas, and that is what has been done. And that is what has led to so many new drugs being approved for sarcomas within the last 8 years, right? We got pazopanib, which is Votrient, which was approved in 2012. And we got tazemetostat, which got approved just within the last 8 months. And then we got 2 new drugs approved for GIST tumors within the last 6 months. So this is all because we are understanding the disease process better. And also, of course, the science has helped understand the molecular genetic composition of these tumors in a better way so that we can utilize the pharmacology and the science and the delivery method to be able to put in an integrated fashion so that we can make things work better for the patients who might have the most benefit. I think that is probably what I would say has been the revolution in sarcoma from an oncology viewpoint.
That's a great answer. Now, I was actually just thinking of our sarcoma biobank. How do you think in future that we can use that biobank, from a personalized standpoint? Do you foresee us, having a patient go to biopsy, have their tumor banked, and then having, an outcome from a systemic treatment side of things? Do you think that that's in the works in the future for sarcoma care?
Again, that is a really important discussion because, again, there has been a lot of centers have done this kind of biobanking. Mayo Rochester has one of the biggest biobanks in the country. So there's a lot of sarcoma samples which are being collected either at biopsy or when patients undergo surgery, and they annotate each of the sample in terms of genetic testing, what they have found, and also the clinical outcomes of the patient. So if you want to go back and look, how did this patient do with this kind of X type of treatment, and what was their genetic makeup of the tumor, it's fairly easy if you have a well annotated system to know the outcomes. Again, the biodiscovery is a very fast moving field. So we may find on a genetic profiling test result some words called VUS, which is basically means variant of unknown significance. Meaning right now, we think the genetic change, what we see in the tumor, we have no idea what that means. But fast forward a year or 6 months or 5 years, that may mean something. And that something may translate to a meaningful treatment option with that genetic abnormality. So again, if we know where we have started and where we are going, I think it's easy to track our path as to how we could have done differently, or we can go back and look and say, hey, this is what we found. Let's run the test again, because now it seems to be an important clinical change. Let's go back and check that tumor again and see if it's still there, or treat the patient with this particular treatment, because now we know it's a clinically meaningful change. So again, a short answer for this long-winded discussion. Yes, I think it's good to collect as much the tumor samples. As we were discussing recently, we want to collect as many biopsy samples as well, because there could be a difference in genetic expression between a biopsy sample and a tumor sample taken during surgery. And also, more importantly, maybe before treatment or after treatment, because certainly there'll be change. And we know about clonal evolution, wherein there'll be pockets of cancer cells which might change form over the course of the disease. And that has been well studied in pancreas cancer and colon cancer. So I'm sure that is happening even in sarcoma, because we see some patients who start off with a low-grade sarcoma and they transform to high-grade sarcoma. Certainly because there is a genetic change happening as we speak, which makes that a higher grade tumor. So if we can intervene early on, if in such a situation, we might be able to abort the process and maybe change the biology and their outcomes. So I think there are a lot of potential.
I think in my field, the biggest change that's affected care on a day-to-day basis is the incorporation of imaging into radiation. So what we call image-guided radiation. So that has to do with the planning. So the sophistication of the planning of the radiation has increased dramatically over the last decade because of computer algorithms, and also because of the imaging technology, and then the ability to image patients and tumors right before you deliver treatment, which allows us to use smaller margins and therefore reduce side effects and hopefully improve long-term function. That's what I would say on a day-to-day basis is the biggest change in the last decade in how we design and deliver radiation. In the next decade, we're certainly interested in different types of radiation, for example, proton beam here at Mayo Clinic. When we talk about radiation, we're typically talking about X-ray therapy. And X-rays have a downside in that they just go through and through the tissue. We're able to shape the high dose of radiation quite well with sophisticated planning and computer-driven technology. But there's a limit, because the beam goes in one side of the body and out the other. So when you're talking about planning a complex shape of a sarcoma in a confined space, for example, in an arm or a leg, and you don't want to expose the whole circumference of the leg to radiation, even with sophisticated X-rays, that can be a challenge. Or when we're trying to give a high dose of radiation to a sarcoma in the pelvis where there might be intestine nearby, there's only so much we can accomplish with X-rays, whereas protons, because protons are charged particles, they interact with tissue in a different way, and they actually stop. So they travel to a certain depth, deposit their energy like a depth charge, and stop. And so we're able to control the dose quite a bit more with protons rather than with X-rays. Now, protons haven't been proven to be better than X-rays, but in many patients, we are using protons because it facilitates a much more straightforward delivery of radiation, and in some patients allows us to escalate the dose to where we can increase the chance for cure, as I said, especially in patients who may not be eligible for surgery. So I think that'll be the most interesting area of research in the next decade.
just to build on that, from my standpoint, from the surgical side of things, the capacity of imaging and 3D printing in particular, I think, is what has advanced the field from the orthopedic standpoint. When I was a fellow working with Dr. Beauchamp, one of our orthopedic oncologists here at Mayo Clinic, we had a 3D printer in the back office, which we still have there now, actually. And I did several other fellowships internationally where nobody was talking about 3D printed models. And so he was one of the first that really sort of pioneered the development of 3D printed technology, in particular for the use of orthopedic oncology. And the benefit of that is that you truly have a personalized approach to surgery and innovation, so that if a patient comes in with a very complex tumor in the pelvis, which is quite difficult to resect, and we may not have had a really great surgical solution for reconstruction, or at least a subpar solution, now we have the capacity not only to get closer to the tumor in the sense of sparing some bone, for instance, and tissues in a very complex anatomy of the pelvis, and then designing a reconstruction that is actually perfectly fitted to the patient's anatomy. We have several patients, many patients actually, who have this type of reconstruction over the last 11 years or so, and some of them are doing great things even from a sporting standpoint. So I think that kind of technology, which is allowing us to do more conservative surgery and reconstruction that's really patient specific, has really dramatically changed the landscape. And it's very exciting to look at how patients are able to improve their quality of life, health-related quality of life in particular, and their function, which we think is directly related to those things. And of course, not all resections are going to be equal. And so these, just as Dr. Seetharam mentioned, these are very disparate types of cancers in very different locations. But this does allow us to tailor both rehab or prehab, as well as a surgical resection and reconstruction to a patient's own unique anatomy. So, my goal for the future is really to have somebody come in, they get their diagnosis, they get their genetic testing. Maybe we've individualized their care from the chemotherapy standpoint and the radiation standpoint, targeted to the specific tumor subtype that they have. And then they also have a reconstruction and resection that is tailored to their own unique anatomy, that maximizes their quality of life and function and, in line with their goals, their personal and family goals and work goals as well moving forward. And so I'll just, Dr. Hinckley, are there any other questions that we haven't answered at this time?
Nothing else right now.
Anyone else, any other comments?
Dr. Goulding, what about the problem that is a persistent problem in sarcoma, which is the patient who goes to their local doctor with a lump and they're told it's probably nothing, let's just remove it, and then oops, it comes back as cancer or sarcoma. And there maybe hasn't been a lot of imaging or a lot of planning, and then they come to us as the specialists. What sort of challenges does that leave us and the patient?
Well, that's a great topic, and I'm glad that you brought that up, because I really didn't touch on that much in the presentation. And in fact, there's quite a number of people who come to see us with this kind of problem. So much so, and this is not unique to Arizona or the United States, this is really an international problem. And so much so that we actually have a label for it called whoops surgery. And that
or
means
unplanned excision.
or an unplanned excision, but there's a colloquial term that applies to that as well. And it's a really challenging situation. And the reason is because patients who have never been operated on before and who have an appropriate biopsy in line with the approach that an orthopedic oncologist would use to safely remove a tumor is very different than somebody who comes in and who has large incisions, or who may have incisions in directions that we might not have otherwise placed them. And there's been now contamination of the field. So as an orthopedic oncologist, I need to essentially remove all the area that's been touched by the other surgeon. And that makes reconstructive surgery much more difficult. You know, it could be something as easy as just closing the skin afterwards if it had been done in an appropriate fashion or a planned fashion with appropriate imaging, to something that can result in amputations of lower extremities, upper extremities, skin grafts, free flaps, or tissue or transfer of tissue from other locations needing to cover the area that's been operated after it's been re-excised. So these are very challenging problems from a surgical standpoint, and from, you know, a radiation standpoint as well. So there's a lot of education that's going on, and a push to educate surgeons and other subspecialties because of the rarity of it. Sometimes a primary care provider will see maybe 1 or 2 sarcomas in their entire career. And so many patients will see up to 4 to 5 other providers before they get to see us. So you can imagine that the amount of workup that may have been done, or other surgeries. So what I tell patients and what I tell providers is, and what I especially educate our residents during their time here at Mayo Clinic, we talk about basically not whipping out any lesion without knowing what that might be. And so that involves, you know, lumps that are bigger than 2 centimeters would typically get imaged either with an ultrasound or an MRI or CT scan. And then understanding what the relationship of that tumor is to surrounding structures, so as to avoid any contamination of bone or nerves or blood vessels in the area, to facilitate a better reconstruction. So lumps that are bigger than 5 centimeters absolutely need imaging, and usually they'll need to see an orthopedic oncologist or have a biopsy. Lumps that are over 2 centimeters and growing rapidly, those also need to be imaged. And so I think that this is not a problem that will likely go away, but it is a problem that can be improved with, you know, the appropriate imaging and the appropriate planning. Because the last thing we want is, you know, for patients to have really morbid procedures for something that otherwise might have been salvageable. What are your challenges from the radiation standpoint? Because it's not just a surgical problem. How do you approach a patient who's had a so-called whoops or unplanned procedure in terms of your sophisticated planning that you're doing for preoperative radiation?
Well, the biggest challenge is if it's done without any preoperative imaging. So then the patient comes to us essentially with the tumor removed. And so to figure out the extent of the tumor, where it stopped and started, what other tissues in that area were at risk for having microscopic cells left behind, becomes really challenging if no preoperative imaging was done. And then it ends up requiring a much bigger volume of tissue to be exposed to the radiation, which just makes the radiation planning more challenging, the risk of side effects going up, and the risk of poor functional outcome go down. And the studies are pretty clear that the outcomes are compromised, probably because the radiation in the surgery is more challenging. Now, if they've had some sort of imaging, then it's a little bit easier to reconstruct because we're used to giving radiation post-operatively. And then it may just be a matter of taking that preoperative imaging and incorporating that into our plan to do radiation as a part of a planned re-excision to do a more formal operation. So the biggest challenge is for patients who have never had any imaging while the tumor was there in the first place.
Yeah, I definitely agree with that. I think that a good rule of thumb is tumors that are bigger than 2 centimeters and growing rapidly, or bigger than the size of a golf ball, which is around 5 centimeters, should have some form of imaging. You know, lesions that are 2 centimeters and have been there for 20 years but become bothersome, you know, these can sometimes be removed as long as they're superficial to the layer of fascia that we have above the level of the muscle. But anytime anything gets deep down in the extremity around muscles and blood vessels and nerves, it should really have imaging before those lumps are removed. And you know, I'm very open with my colleagues. Many of them have my cell phone, and many of them will just call up and say, "What do you think of this? What do you think of this lesion? Does it need a biopsy or not?" So there's a lot of communication that goes on, and I think having good collaborations with physicians working in other centers is very important to try to mitigate some of the risk around these types of unplanned excisions as well. Well, I think if there aren't any other questions, Dr. Hinckley.
Not at this point. I think that was very thorough.
Great. Well, this was a great session. I really appreciate everyone's time. Thank you for joining us, and we'll be happy to take any additional questions by email. And I think that you'll have a link provided as well for some additional videos around many of the topics that we've discussed today and beyond. So I'd like to just thank Dr. Seetharam and Dr. Ashman, as well as Dr. Rebecca for their time, Dr. Hinckley. And then I would just like to also acknowledge some of the other surgeons and other providers and all the other subspecialties that help us do our job. And thanks again for a great session.
Hope we can get back together in person in the not too distant future, and maybe next year in person again.
That's right. Okay.
All right.
Take care, everyone.
Thank you.
Stay well. Stay
Okay.
safe.